Now we have a keynote session by Dr. Sanjay Chauhan, Scientist and Head, Department of Operational Research, the National Institute for Research in Reproductive Health. Mr. Chauhan will share his inputs on a public health focus on infertility prevention, detection and management. Welcome, Mr. Chauhan.
A very good morning and namaskar to all ladies and gentlemen. At the outset, I would like to thank the organizers, ETHealthworld, for organizing this National Fertility Conclave and inviting me to deliver a talk. And I have been asked to talk on infertility prevention and management in India with a public health focus. The structure of my talk will necessarily consist of some general aspects of infertility, definition, causes, prevention, prevalence, and so on. And in response to this, what is the policy and program of Government of India? And within that, I'll talk about the development of national guidelines on prevention and management of infertility in the public sector. And thereafter, finally, the road forward, what advocacy efforts and what regarding the program rollout and so on. Let me start with the definition of infertility. And we all know that infertility can be primary or secondary infertility. And regarding the definition, primary infertility, in a typical textbook definition, mentions that it's an inability to conceive within 1 year of unprotected intercourse. But we also have another definition, which we call as epidemiological definition. And usually WHO defines that it's a lack of conception despite cohabitation and exposure to pregnancy for at least 2 years. And the rationale behind this 2 years definition is that the logic for a longer period of waiting is based on the long-term studies indicating that in women less than 35 years, pregnancy rates improve from 18% in the first year to 93% in second year. And particularly in Indian situation, women could be labeled infertile often due to social rather than biological reasons. And this will be kind of, again, a good cost-effective strategy for using infertility services since, particularly in health sector, we have limited resources. And if you look at the major national level surveys, like district level health surveys or the national family health surveys, they also use 2 year definition. Regarding secondary infertility, we know it's a failure to conceive following a previous pregnancy despite cohabitation exposure to pregnancy. Looking at the magnitude of infertility in India, really speaking, there is no true prevalence figures. There's a big question mark on that. But roughly, we do accept that the prevalence is between 10 to 15%. And taking that prevalence into account, around 30 to 40 million couples could be infertile in India. WHO estimates that around primary infertility, secondary infertility between 3 and 16%. But secondary infertility basically is always higher than the primary infertility in terms at least 4 times of. The National Family Health Survey, the recent one also has come out with figures with 2 to 8% of primary infertility. And regarding the states, it varies from India, from state to state in India, and it's from 3.7% in Uttar Pradesh, Himachal Pradesh, Maharashtra, up to 15% in Kashmir. And Kashmir, the infertility levels are so high, maybe because the polycystic ovarian syndrome, which is very prevalent in Kashmir, it could be due to that. But what is important is this high prevalence of infertility is concentrated in women belonging to the poorest wealth quintile, married before age 18 years, and those women who have not gone to school or having less than 5 years education. And also it's much more concentrated in scheduled caste tribes. Causes and prevention of infertility, if you look at, we all know female factor causes, male factor causes, and also there is an entity almost 1/3, which are unexplained infertility, what we call as. But mostly infections are responsible for causing infertility. Tuberculosis, which causes tubal scarring, also chronic PID important, and endocrine problems like PCOS, as I said, and as far as health system is concerned, what is important is the woman undergoing unhygienic obstetric process, septic abortion, its complications, postpartum, postpartum complications. So prevention of this necessarily means the looking at the health system by strengthening the maternal care in public and private sector as well. Well factor, varicose tobacco, smoking, alcohol, and obesity, and that's almost like a individual-oriented and public sector interventions can also address this problem. As I said, PCOS is a big problem now in India. It's had taken an epidemic form, and this study what we have done in Mumbai is a community-based prevalence study among young girls, and it was eye-opener that how much prevalence of PCOS there is among young girls. And what the study indicated that 1 out of 4, that is 22.5% of the screened young girls population had polycystic ovarian syndrome as per the Reproductive criteria. This is also reflected in our institute's infertility clinic, wherein what we found that 64% of the women who attend to this infertility clinic had a PCOS problem with them, and that was one of the cause for causing infertility among them. So, historically, if we see, there is a low prioritization of infertility in the public health sector. Why? We all know, because the population problem was there, and therefore much emphasis was on family planning services. Since 1952, it was launched first in India. And also some reasons, other reasons were also there, that we had a high burden of infections such as tuberculosis, HIV, diarrhea, and also the burden of infant mortality, maternal mortality, high fertility rates were also very high. And so infertility, and already we had so much, since beginning only, hardly 1% of GDP goes into the health budget. And in that scarce resources, most of these life-threatening problems get preference, and infertility has always taken a backseat. The other also question mark is there on giving infertility historically preference. So one always asks the question, is it appropriate to worry about infertility in a country where people do not have access to safe drinking water, food and shelter? And because of all these things now, we know that this infertility problem has been largely ignored by research, by policy and program. And that has resulted into some ground realities regarding infertility services in the public sector. We all know family planning gets more weightage, and the infertility services are more concentrated in the private sector. And also, since it is not available in the public sector, in villages, in the large slum areas, usually walks and even babas also give some kind of advices and services to the population. The other aspect is that we should also understand that infertility is a reproductive health and human rights issue. And the reasons behind it are divorces happen due to infertility, and also women also is subject to mental and physical violence at the hands of in-laws. The other problem is that social stigma and exclusion is that a woman who is labeled infertile usually is excluded from auspicious ceremonies, and there are also lack of treatment problem is also there. So considering all these things, if you look at the current status of infertility in the public health system, at the bottom, that's a primary care, where the community health centers, rural hospitals, primary health centers, sub-centers are there. There are no guidelines for infertility, and therefore no services also. And even at the secondary level, at district hospitals and private hospitals, again, no guidelines and no services. Tertiary care, yes, some medical colleges do give services, but super specialty hospitals, specially dedicated to infertility services, they also give services. But there are private ART clinics also. And guidelines are there. This national guideline for assisted reproductive technologies has been existing since 2005. So after, but at the primary and secondary, since nothing was there, we as an institute, which is a collaborating center of WHO, and there are about 4 collaborating centers on reproductive health and research of WHO in India. Maybe they are located in AIIMS Delhi, PGI Chandigarh, Sevagram Medical College, Sevagram, and our institute. So a decade ago, when we had a meeting of Southeast Asia Regional Collaborating Centers, I floated this idea of developing the national guidelines on prevention and management of infertility in the primary healthcare system. And my other collaborating center colleagues also seconded it. So we decided to join hands and work towards developing this guideline document. And we had funding from WHO, and a group was formed who started working on desk research, review of literature, review of available international guidelines, and the clinical section, the prevalence, the causes, all those things were finalized based on the available literature and what kind of evidence was available for clinical management as well. But what we were struggling with for the primary health sector or secondary health sector, there was no information with us at all. What is happening? What is the ground reality and rural areas? What are the doctors' knowledge? How they are trying to manage this infertility with the limited resources? And what is the perception of community also? What is the coping mechanism? How they are struggling with this? So we designed a nationwide study, which was done in 12 states of India, and each district representing those states. And we had some eye-opening findings from that study, which was very helpful in developing the operational or the health system part of the guideline. So the findings of the nationwide survey was a kind of eye-opener to us. And we look at how at the basic and advanced services and treatment facilities that those facilities the primary and secondary healthcare services, and that includes PSCs, CSCs, and district hospitals. Regarding the semen examination, what we found that it was hardly available at primary centers and community health centers, but at district hospitals, about three-fourths of district hospitals did have this facility. But the point to be noted is that they were not being used for infertility services. They were only being used for as a kind of proof of success of vasectomy operations. Coming to advanced services for diagnosis of infertility, few district hospitals had facilities of sonography, transvaginal hysterosalpingography, folliculometry, endometrial biopsy, histopathology. But there was no facility for diagnostic hysteroscopy or hormonal test at all. Regarding the services available for treatment of infertility, ovulatory induction with timed intercourse, ovulatory induction with clomiphene, or ovulatory induction with gonadotropin were available at many of the district hospitals. But IUI or operative hysteroscopy, operative laparoscopy, these were not available. Minor surgeries for male varicocele and all those, they were also available. Coming to the prevention of infertility services, and we know STI program, the tuberculosis, the safe delivery, they were available. Now, but consider the magnitude of infertility in the community. So the question arises on the quality of such services, how they are being done. Availability is not just a thing, because quality is important as far as the infection prevention is concerned. First trimester and second trimester abortions were okay with the district hospital, but they were not available at primary and secondary levels. We also collected information on community's perception on infertility. And the major finding which came out was that this childlessness was associated with anxiety, depression, and stigma, particularly among women. There were a lot many misconceptions, and there was a fatalistic attitude towards it, like infertility attitude to factors beyond one's control. It's God wish, my fate, past sins, etc. And most of people considered infertility as a disease, and causes were identified among men too. But labeling and blaming was directed towards women. And government sector was perceived as not providing treatment for infertility. This was cited as a reason for people's reliance on traditional healers and Bhagats or Babas. There's a quote here that how infertility services are neglected. That government promotes program on family planning through media, but there is nothing on infertility and related issues. The cost of the treatment in the private sector was a major challenge, leading to incomplete treatment and failures. Regarding adoption, this was considered only as a last option, and preference was given to a child within the family. So overall, what this study indicated, and that there was a high rate of infertility in the study districts endorsed by doctors, and I can say Northeast had those districts had very high level of infertility prevalence, those particularly the Manipur and Kakkar district of Assam. The inadequate facilities and services, particularly at community health centers and primary health centers. And it seems that the system perceives that addressing infertility is not expanded, as depicted in the available resources relevant to infertility management, but not being used. And there seems to be very little awareness about the preventable causes of infertility. I think this we should note that, and because this is usually neglected. And these causes such as RT-STI, unsafe abortion, and deliveries. And therefore, what we realized that when we were making the operational part of the guideline, there will be recommendations for putting a lot of input resources for infertility prevention and treatment services in the public sector. So finally, taking into consideration the study's finding, we drafted this guideline, which has necessarily 3 sections. And section 1 had general aspects of infertility, which covered the epidemiology, the current situation of infertility management in India, and the prevention of infertility. Section 2 focused on clinical part, and this was management, that is investigations and management of infertility as a male factor, female factor, and unexplained infertility. And we added another important chapter, that's an adoption. Adoption as an option to manage infertility. And section 3 was necessary on the public sector management, and it had chapters covering prevention of infertility by training the program under the National Rural Health Mission, then assessment and management of infertility primary health care system, service delivery framework, which I will briefly describe in the next slide, and what minimum standards and quality of care is required for infertility service delivery. In addition to this, we had important annexures like performer for infertility workup, semen analysis, folliculometry, hormones level, the normal ones, then the essential accessories, equipment, drugs, the IEC material, referral forms, and list of adoption agencies in India also, since the chapter was there. So there was a good guidance on how to go about adoption. So service delivery framework, this is in a nutshell I would describe that if a couple is unable to achieve pregnancy, he will be approaching the ANM or ASHA, which are located in village and sub-centers. And these health functionaries can very well take history and counsel them on information on fertile period. At the PSC level, there is a medical officer, a lab technician, and this person can, in addition to history taking, he can take the clinical exam from couple, and semen examination can be done by the lab technician. And at the community health center, where there is the presence of gynaecologists and surgeon, they can do all down below, plus hysterosalpinography, ultrasonography, folliculometry, and ovulation detection with time intercourse. And above that, the district hospital, where there is the gynaecologist, surgeons, and other staff is also the lab technicians. So in addition to the down below, they can do hormonal tests, ovulation induction, gonadotropins, IUI, endometrial biopsy, and diagnostic laparoscopy. And throughout this, in the guideline, what we have recommended, there should be counseling on adoption, because we know that there are so many orphans in India, and there are no takers. So if really this kind of message goes into the community, that adoption can also be an option to manage infertility, I think even among service providers, in fact, it will be a good move. So way forward now, we have guidelines which were submitted to the ministry almost 5 years back, and they are yet to set up one more committee to look at that so that it can be included in the national program. So advocacy is important here now, advocacy for inclusion, this guideline in the policy. And I remember we have answered at least 5 to 8 parliament questions in the last 5-6 years, where a member of parliament had been asking about the prevalence of infertility, the PCOS problem, and how the government is going to address them. And we had been answering them. Yes, we have a guideline and we will be operationalizing it. Second thing is that prioritization of service in primary and secondary healthcare services. Because this is important, as 90% of couples do not require assisted reproductive techniques. 8 to 10% is required IVF. So, and what we learned from the top gynecologists who are in our committees where we work on the guideline, that 40% of the couples do conceive just on counseling on fertile period. Next is costing. So costing of the program is important when we want to roll out in the national program. Costing of this primary secondary care at below district level, and also important is IVF. So IVF costing, when we want to do it government sector, that is also important. Right now, we know that IVF facility is available at AIIMS Delhi, PGI Chandigarh, CMC Vellore, MMC Delhi. But in the government sector, in other hospitals, it is still not available. And what I can share that the government is planning, and they have asked us to do costing of the IVF package, which can be put up in the PMJY or Ayushman Bharat scheme. The next part is that once all these things are included in the policy, the costing is done, we need to upgrade the facilities of primary and secondary health care, where those facilities can be provided, and at the same time, equipment and supplies can be there. And at the same time, training has to happen of all the healthcare providers, doctors and lab technicians, and even ASHAs and ALMs. And thereafter, this program can be rolled out at all the levels of health system, and concurrently, the basic research, the clinical research, and the implementing research can be done on infertility as being done for all other health problems. So finally, it's uphill task, what I see, and particularly in this COVID time, last 2-3 years. And let me share that I am the member secretary of the National Task Force on COVID-19, chaired by NITI member Dr. Paul. And we have been struggling last 2-3 years. At one end, I am associated with that priority problem of India. At the same time, I'm trying to advocate the most neglected aspect of the health, and that's infertility. But finally, we must remember that family planning must also mean planning for families. And planning for families, we need to focus on infertility management, right from the primary healthcare system to the super specialty, where they provide the IVF and assisted growth technology and facilities. Thank you. Thank you so much.
Thank you, Mr. Chauhan, for giving us all the valid points around infertility prevention, detection, and management. Now we'll take a short break. Before we go for this break, we would like to launch our exclusive digital coffee table book, ETHealthworld Innovatory Gynaecologists of India, a prestigious limited edition book that will feature the top gynecologists from India, collating their inspiring success stories. Here is an AV about the book.
Many couples have struggled to complete their families. Emotions have been shattered. Smiles have ceased to exist. Amongst all of this, there's one thing constant: the dedication and efforts of gynecologists to help those wanting to be parents fulfill their dreams. Healthcare necessities and innovation go hand in hand. ET Health World brings to you the stories and efforts of IVF specialists that have brought smiles to people by assisting them in embracing parenthood. With the deployment of advanced technologies in fertility treatment, these top gynecologists from India are working towards better fertility outcomes and ridding society of the stigma attached to infertility. Their efforts need to be recognized. Hence, launching the coffee table book, ET Health World Innovatory Gynaecologists of India. ET Health World's comprehensive handbook on the fertility industry's stalwarts, featuring selected gynecologists from various zones. Our exclusive coffee table book titled ET Health World Innovatory Gynaecologists of India is a prestigious limited edition book that will feature the top gynecologists pan-India.